lab test meth mouth. Since the stem of the question states that the drug reverses the direction of the norepinephrine transporter, we know that it's an amphetamine. Cannabis may cause some dry mouth, perhaps due to inhibition of parasympathetics. Ethanol can inhibit antidiuretic hormone release, which can lead to dehydration, kind of a stretch. Morphine also inhibits parasympathetic activation of the salivary glands, and scopolamine is an antimuscarinic. Here we have a 55-year-old male who has chronic xerostomia secondary to irradiation to treat esophageal cancer. Why should he avoid Sominex diphenhydramine to treat his insomnia? A. Antihistamines further reduce appetite. B. Antihistamines worsen nausea. C. Antimuscarinic effects worsen dry mouth. Or D. Antimuscarinic effects will worsen nausea. The correct answer is D. Antimuscarinics, the tropes and scopes, are going to worsen dry mouth. There are three broad categories of action that cause dry mouth or xerostomia: decreased parasympathetic tone, increased sympathetic tone, and dehydration. Of these, direct-acting antimuscarinics decrease in parasympathetic tone and methamphetamine activation of alpha-2 receptors are probably the most important. A 64-year-old female complains of severe pain and difficulty swallowing. Endoscopy reveals the presence of esophageal ulcers as seen in the photo. Her medical history is significant for osteoporosis, and she has a severe anaphylactic allergy to aspirin. What drug is most likely responsible for the ulceration? Alendronate, calcium carbonate, ibuprofen, iron, or sucralfate? We see from the stem that she has osteoporosis and a severe allergy to aspirin. Therefore, the best answer is alendronate, the bisphosphonate used to treat osteoporosis. It has a high risk of esophageal ulcer, so this is why bisphosphonate should be taken with a full glass of water and the patient must remain upright for 30 minutes after taking it. Calcium carbonate or Tums antacid, probably not erosion. Ibuprofen, NSAIDs can cause erosion, but since she has that aspirin allergy, she shouldn't take it. If you yourself take ibuprofen, always make sure you take it with lots of water. Iron, ferrous sulfate, may also cause esophageal erosion, but postmenopausal women are less likely to need an iron supplement. Don't worry, I would never do that to you on an exam. Sucralfate is a band-aid for the stomach. It's not likely a cause of esophageal erosion, though it can cause some constipation. To summarize, drugs that increase risk of esophageal erosion, the biggie is going to be those bisphosphonates like alendronate, which is Fosamax. Patients should take with a full glass of water, not lie down for at least 30 minutes. Iron or ferrous sulfate, NSAIDs like ibuprofen. For your information, solid potassium supplements and tetracycline antibiotics can also cause esophageal erosion when they lodge in the esophagus, so most meds really it's a good idea to take with plenty of water. A 44-year-old male has atrial fibrillation with a rapid ventricular response and severe gastroesophageal reflux disease, GERD. What drug would best manage his ventricular rate? Amlodipine, diltiazem, phenoldiazepam, metoprolol, or verapamil? The first thing we need to do is control his ventricular rate. So we need either a class 2 or a class 4 antiarrhythmic that automatically eliminates amlodipine and phenoldiazepam. Now the second part of this question is, what are we going to do to not worsen his GERD? Calcium channel blockers like verapamil and diltiazem will worsen GERD. Therefore, our best answer is metoprolol. The lower esophageal sphincter is smooth muscle, and it's going to contract when calcium calmodulin activate the myosin light chain kinase. For example, when acetylcholine activates the GQ protein coupled receptors, the M3 receptors. What effect did we see from calcium channel blockers? Well, when we block calcium channels, there's less calcium entering the smooth muscle, therefore we get relaxation. The LES relaxes when myosin phosphatase is active. Myosin phosphatase snips the phosphates from myosin phosphate complex. The phosphatase is activated by cyclic GMP and cyclic AMP, things like nitric oxide, dopamine, norepinephrine, and my drug of choice, caffeine. To reiterate, GERD occurs when the LES is relaxed. Things that relax the LES include decreased calcium or decreased M3 activation, antimuscarinic drugs, calcium channel blockers, and don't forget peppermint. It's also relaxed with increased cyclic AMP, cyclic GMP, sympathomimetics, dopaminergics, caffeine, phosphodiesterase inhibitors, and nitric oxide or nitrates. A 3-year-old develops bloody vomiting and diarrhea after eating mother's prenatal vitamins. Opacities are seen on X-ray as shown. The patient's tachycardic, diaphoretic, hypotensive, and in obvious distress. Deferoxamine is appropriately administered. 1 month later, the child has GI obstruction. GI and hepatic scarring are noted. What component of the vitamin is likely responsible? Beta-carotene, docosahexaenoic acid, ferrous sulfate, or folic acid. Since the child was given deferoxamine, I hope that you guessed that it was iron or ferrous sulfate. Iron is radio-opaque on X-ray. Iron causes damage to the organs that it contacts, and it can lead to scarring if the patient survives the liver damage. Beta-carotene is plant-derived vitamin A. It's not as hepatotoxic as retinol esters. Polar bear liver contains enough retinol esters to kill over 50 adult humans from a single liver. Natural vitamin A is stored in the liver, and excess can be hepatotoxic. Docosahexaenoic acid is an omega-3 fatty acid, and folic acid does not accumulate in the liver. Hopefully this is an easy question. 25-year-old male presents with upper right quadrant abdominal pain, nausea, anxiety, tachycardia, and scleral icterus. He admits to an intentional overdose of several meds after a fight with his partner. Lab studies reveal elevated INR, elevated hepatic enzymes, and hypoglycemia, all of which are consistent with liver injury. He is appropriately treated with N-acetylcysteine. What drug most likely caused his hepatic injury? Acetaminophen, aspirin, diphenhydramine, esomeprazole, or ibuprofen. I hope you recognize this as acetaminophen or Tylenol poisoning. It's one of the leading causes of hepatic injury. Alcohol is another one, and the combination is much worse because, again, ethanol will increase formation of the toxic acetaminophen metabolites. I want to bring up a point about aspirin. In pediatric patients, those less than 18 years old, who have a viral illness, aspirin could cause Rye syndrome, which is a liver injury that's associated with projectile vomiting and altered mental function, probably due to an underlying mitochondrial dysfunction. As a reminder, acetaminophen is actually toxified by the liver, particularly when CYP2E1 is induced, as with chronic alcoholism, compounded by the fact that chronic alcoholism leads to malnutrition and depletion of glutathione stores. The specific antidote for acetaminophen poisoning is N-acetylcysteine. It helps replace glutathione stores. Different hepatic toxins can produce different hepatic injury patterns. The main point is that the liver is often the site of injury because it gets exposed to so many toxins, even forming the toxin in the case of acetaminophen.